We're now going to continue with our speaker, Dr. Lusine Aghajanova, Clinical Associate Professor of Reproductive Endocrinology and Infertility and Obstetrics and Gynecology, or OB-GYN, at Stanford University. So welcome.
Hi, everyone. I'm very worried about having technical issues, so please tell me how things work. I'll share my screen. Do you see the correct view? Yeah, yes. Can you see the, okay, cool. Okay, so, well, thank you very much for the invitation. I am very honored and feel very delighted to be here today and being able to talk to you about the topic I'm very passionate about, work with every day. And I think it's just great that this is considered to be important for this forum. I do have very warm feelings towards everything Swedish, and I deeply respect all the significant contributions to science and medicine that you make. And I will talk to you today about advances in fertility preservation techniques for every life stage, every age and situation. Okay. Yeah. So I have no relevant disclosures. I do want to say that fertility and infertility is a sensitive topic. There are many ways to build families, you know, usually this talk is geared towards people with ovaries. We will talk today about methods of fertility preservation. We talk about elective fertility preservation or planned or social. We will talk about oncofertility and cancer survivals, fertility preservation for pediatric population, and if we have time, I would love to talk a little bit about fertility preservation from transgender population. So first, some definitions. Infertility is a disease as defined by WHO, and when people, particularly heterosexual couples, are trying to conceive for over 12 months when the female partner is younger than 35 years of age, or 6 months if female partner is older than 35. And this is kind of the first mentioning that I will be doing multiple times throughout this talk about the significant impact of female age on female reproduction. And infertility is when there is an ability to achieve pregnancy based on various medical, sexual, reproductive history factors, age, physical findings. And also need to say that kind of recently, at least in the US, this was defined, the inability to get pregnant for people of all sexual orientation. Fertility preservation, on the other hand, is the process of saving or protecting eggs, sperm, or a reproductive tissue so that a person can use them in the future to have genetically related children. And that can be elective, as we already mentioned, or non-elective, such as in oncofertility patients or transgender population patients. Just quick kind of, you know, physiology and anatomy background in case not everyone really knows exactly what I'm talking about. As you can see, I hope you see my cursor. So these are the internal reproductive organs of a woman. And, you know, for reproduction, sperm gets in the vagina, travels through cervix, through uterus, goes through tubes. And if there is an egg coming from the ovary to the tube, here, egg comes from the ovary to the tube. And if there is a sperm around, it gets a chance to fertilize the egg, then embryo is formed, and then this embryo travels back to the uterus through the tube while developing, and then it can implant. And here is motile sperm, which we also very much need. So that's very cool and kind of amazes me every day. Such a complicated process, so many things can go wrong, and hence, you know, we are all here. Now let's talk about the age. There is a very well-known age-related decline in fertility. And the graph here on the left is very interesting. It's a combination data from a marital, natural, spontaneous pregnancy rates, fertility rates as a function of age of the woman, indicated for different populations between 16th century and the 20th century. And many of these were based on the church records. And as you can see, there is a decline of fertility, you know, since 20s, but there is a sharper decline after 35. So the fact that fertility does decline has been established quite well. And here on the graph on the right side, you can see how a purple line is percent of maximum fertility. Does go down, and there is kind of sharp decline around, your mid-30s. And together with the decline in fertility, there is also decline in there's an increase in the miscarriage rate. So we will talk about why this is happening because of the quality of eggs as well. Let's move on. And here a little bit more. So decline in fertility due to kind of decreasing ovarian function can be divided into what's happening to the eggs or oocytes. And so it's well established that there is decline in numbers of eggs. So there is a drastic comparison in male and female physiology in reproduction in the respect that men make sperm every day from puberty until they die. The quantity can decline, but they always have sperm. Women, on the other hand, are more in more disadvantaged situation because we make all the eggs we will ever have and use when we are fetuses. So if the question can be, when do women have the greatest numbers of eggs? And women have their greatest number of eggs when they are fetuses between 16 to 22 weeks of gestation. So that's it. After that, there is continuous decline in numbers, as you can see on the right here. Then, and the highest number of eggs that women have as fetuses is about 5 to 7 millions. By the time we are born, after substantial decline, we have about 1 to 2 million eggs when we are born. The decline continues. By the time we're in puberty, we have about 400, 500,000 left. So we haven't even used our eggs. We already lost so much. And so this decline in numbers continues. And when we reach the average age of menopause, which is about age 50, 51, we have less than 1,000 eggs left. So that's kind of pretty sad situation overall with women. And that's kind of everything we do stems from that. Now let's understand ovarian reserve. There's a lot of discussions and a lot of kind of myths and stories around what is ovarian reserve and what can it predict, and also lots of misunderstandings. So the main two markers of ovarian reserve when we are trying to estimate, okay, well, how many eggs we have there, is anti-Mullerian hormone, AMH, and antral follicle count, which is, so antral-Mullerian hormone, AMH, is a blood test, and the AFC count is an ultrasound test. And they are the most sensitive and reliable markers of ovarian reserve, and they usually recommended to be done together. Important thing to remember is that those markers of ovarian reserve do not predict current reproductive potential among women with unproven fertility. It's not a test for quality. It's not a test for fertility. Women usually come and say, I want to check my fertility and I want to know if I can get pregnant. Well, that's not what AMH does, or antral follicle count. What it does, it actually tells us, gives us the numerical estimation of ovarian reserve and helps us predict how many eggs approximately we will get if a woman will go through an IVF cycle. So it gives us information about quantity and not the quality. And so results of ovarian reserve tests cannot be used in predicting the likelihood of getting pregnant actually in women with infertility, or for that matter in anybody else. So now we talked about the numbers of eggs and quantity can be estimated by ovarian reserve testing. So what about the quality, right? So in addition to the declining numbers of eggs with age, what happens is there is also decline in oocyte quality with age. And that is, at this point, at this moment, in our lives, we cannot estimate that. There's no test that we can do to test the quality of eggs, even though everybody wants that and everybody asks. The way I usually estimate quality, I'm just looking at the chronological age of the patient and tell them, the age, 28, the quality is expected to be good. Age 39 or 45, pretty much should be really poor at age 45. So what does this mean? As you can see here, the best quality is in 20s and maybe early 30s. And then the oocyte quality or rate of aneuploidy, meaning having abnormal eggs, actually increases with age. What does it mean practically? That means that it's harder to get pregnant with increasing age, because if there's an abnormal egg, most likely you just don't get pregnant. If you get pregnant, there is increased risk of miscarriage due to increased aneuploid or chromosomally abnormal egg in reproductively older patients. So what can we do about it? We can recommend, of course, saying, let's get pregnant sooner. Now is a good time, but that's not applicable for everyone. And so the best thing after that we can do, we can freeze eggs or embryos. So we can attempt fertility preservation to freeze what we have now in time. Okay, so let's talk about fertility preservation methods. These methods, I have to say, fertility preservation methods initially came about for to be used in patients with cancer who actually, were known to undergo gonadotoxic therapy, so fertility will be compromised, and that's how all these, methods came about. But now they have been translated to general population and are available to everyone. So what are the available assisted reproductive techniques for fertility preservation in females? There are established methods, is freezing of mature eggs, mature oocyte cryopreservation. If you add sperm there, then we can do embryo cryopreservation. And then here, this is a little bit older graph, where the ovarian tissue cryopreservation is still in the investigational methods. But a few years ago, the American Society for Reproductive Medicine, ASRM, which is our governing body for our profession, actually moved the ovarian tissue cryopreservation from investigational to no longer experimental methods. And then you can also, retrieve immature oocytes from the ovary, perform in vitro maturation of eggs, and then freeze them, which is not very widely performed yet. And then we have future direction, something that many companies and many researchers work on, to create artificial ovaries or to create eggs from stem cells. And that's actually very popular in terms of research now, and there are several attempts on in vitro gametogenesis going in the world to create especially using iPS cells to create eggs and sperm from either somatic cells or stem cells. Now, oocyte or embryo cryopreservation. So both of these methods right now, as I said, are standard of care for fertility preservation that we offer to post-pubertal patients. Patients that went through puberty, have menstruation, their hypothalamus pituitary axis is mature, and they can respond to stimulations. Oocyte cryopreservation is offered to patients who don't have partners, are not interested in using donor sperm, or if the partner doesn't want to do cryopreserved embryos. The estimated success rate with frozen embryos are pretty good. If we freeze embryos, we know a good quality embryo can give us 50–60% of live birth. If we freeze only eggs, it's kind of, freezing eggs with a known potential, but the estimated success rate of a younger egg is between 5 to 7% to become a baby. And the cumulative live birth rate increases with number of eggs you freeze. The more eggs you freeze, the higher is your success rate. So now there is decision-making happening when we talk to patients about, shall we freeze eggs or shall we freeze embryos? And if we have a patient who is single, then we just talk about eggs, okay? And it has very good success rate. It's overall cheaper. It's not experimental for, almost 13 years. And survival is very good, over 95%. And reasonably, if you have good number of eggs, you have good chance for having a baby. Now, if I have couple sitting in front of me, I'm still talking to them about both options, egg freezing or embryo freezing. And the main reason to talk to a woman who has a partner about egg freezing is to preserve her reproductive potential, which is very important concept that I want people to understand. If you freeze embryos, and then you are not together with the same partner anymore, you are most likely are not able to use those embryos. So to preserve reproductive potential, sometimes women choose, or we recommend, to preserve eggs only, even if you are in partnership. So to make an embryo, you have to have sperm source. It's more expensive. It does have more history in terms of more experience and safety data. Again, great survival rate after thawing. You have more information obtained upfront. Like, you already know what you got from your eggs. So you will be able to make decision about if you need to perform more cycles or not right now and then. And if you have good quality of embryos, the success rate and chance to have a baby is quite good. Now, after, in a changing political situation in the US, this may be changing because some people are quite worried about freezing embryo and then having issues with disposition of embryos. And so I already had few patients, even in California, who are considering freezing eggs and not embryos. And the one thing to remember that we have to tell patients that there's no 100% guarantee. I can estimate your chances as high or not very high to have a baby from these eggs. But if somebody gives you a guarantee you will have a baby from frozen eggs, that's not correct. And just some historical information about how successful and how well established these methods are is that the first baby from cryopreserved embryo was born in 1984. And then first baby from cryopreserved egg was born in 1986. So that's quite a history. Here, just to kind of say, both embryo cryopreservation and oocyte cryopreservation is not a long process, but it does take about 2 to 3 weeks. Briefly, to give you a very brief overview of IVF process. So as we know, the egg maturity, growth and maturity and ovulation happens in the first 2 weeks of menstrual cycle. And that's what pretty much we're trying to use and mimic in an IVF cycle. We're not trying to change the biology. So starting ovarian stimulation with medications and getting up to the retrieval when we actually have eggs takes about 2 weeks. Yeah. Now, let's talk a bit about ovarian tissue cryopreservation. So that's another method that I mentioned is available, and that requires removal of the entire ovary, or at least cortical tissue of the ovary, where the majority, you can see the follicles reside. And then embryologists usually dice this ovarian cortex into small pieces to freeze. So that's usually is performed for fertility preservation before cancer treatment, toxic therapy, etc. This is not elective cryopreservation. And this surgery can be coordinated with another procedure, for example, tumor removal surgery or pore placement or bone marrow aspiration, so that patient doesn't go through this just for the removal of her ovaries. And then the goal is that, after the cancer treatment, when woman is cancer-free and now she wants her life back and she wants to have a baby, she comes back and we put these pieces of ovarian tissue back. And one of the ways to put the tissue back is heterotopic ovarian cortex transplantation, when you put it in the sites outside of the ovary and pelvis, for example, under the skin. This is pretty cool. You can stimulate this tissue and then you can do egg retrieval from under the skin. However, it's not as successful, and just, only one clinical pregnancy in humans was reported to date with this method. Orthotopic tissue transplantation, when we transplant these tissue pieces back to the where the ovary was or to the pelvis. And spontaneous pregnancy can be achieved with orthotopic tissue transplantation, or people use IVF. And so that method was more successful. Usually after putting the tissue back and all the revascularization, etc., the function of ovarian tissue comes back in about 2 to 8 months and can last for several months to up to 7 years has been reported. And that depends on age at which the cryopreservation was done, how much tissue was cryopreserved and then transplanted back, etc. But still, given that this tissue is not forever and has overall limited viability, it's recommended to put tissue back when the patient is ready to achieve the pregnancy. Technically, this functional ovarian tissue is able to produce hormones and also alleviate menopausal symptoms, but this very cumbersome technique and procedures are not used for managing menopause. So just to give you, actually, I probably will skip this because I know I don't have much time left, but the point is that the recovery of follicles is not very efficient, and IVF cycles are not very efficient after this. We do have babies born with this technology, but it's not as successful as it could be. So, the research and the improvement of techniques is continued. Now, I just want to mention here that what is cancer doing to us? There are a lot of, now with improved medicine and level of medicine, especially in the US and Europe and developed countries, cancer in many patients is being cured or becoming chronic disease. So as I said, what do they want now? They want a normal life, and they're coming to us because now they want to have kids. And if in the US only, there is approximately 500,000 of men, women of reproductive age with history of cancer. And what cancer does, it actually does narrow or completely, interacts with your fertility window. So chemotherapy, radiation to brain, to ovaries or uterus, surgery, bone marrow transplantation, everything affects your fertility window, and people are either becoming infertile or have very narrow fertility window. And so what is available? What is the technology available for us when patients come to us with cancer and try to preserve fertility? If the girl is prepubertal, before puberty, pretty much the only thing available is ovarian tissue cryopreservation. In prepubertal girls, we cannot stimulate them because their system, hypothalamic pituitary axis, hasn't matured yet and they cannot respond to hormones. In postpubertal girls, we can do oocyte cryopreservation, embryo cryopreservation if we want, or ovarian tissue cryopreservation. And the guidelines from American Society of Clinical Oncology and ASRM, our society, actually pretty much mandates, like really recommends, strongly recommends that every patient with cancer should be assumed to be interested in future fertility, and they should be referred to reproductive specialists for at least having a conversation about fertility preservation if possible. So important thing to remember that if patients want to go through egg or oocyte cryopreservation, they have to have time for it, at least 2 to 3 weeks before starting gonadotropic treatments. If it's not possible, like for example, in some of the hematologic malignancies, in that situation, we don't have time, and some other things are considered, like ovarian tissue cryopreservation. I probably can skip this, that we can stimulate ovaries in less than 2 weeks, and we can technically, for cancer patients, move very fast and start anytime in the menstrual cycle. Fertility preservation also sometimes is needed for patients with non-malignant conditions. Patients with sickle cell anemia, aplastic anemia, thalassemia, Meyer, they need bone marrow transplantation. They need hematopoietic stem cell transplantation. For that, they go through the whole body radiation, and they will also some autoimmune diseases, etc. They will need their fertility to be preserved before that because ovarian function will be significantly affected. And then, patients that are risk for primary ovarian insufficiency, we know their function will be, will be gone after surgery or just because of genetics of Turner syndrome. These patients also count for fertility preservation. And then gender-affirming therapy. Now, for pediatric population, just kind of to mention again, we can use ovarian tissue cryopreservation. We can use oocyte cryopreservation. We usually do not use embryo cryopreservation for them because can you imagine 15-year-old girl and we tell them you have to get sperm? Oocyte cryopreservation is pretty great, so we don't offer that to them. Special considerations for these people, for pediatric patients, is that, we have to be very careful with all the transvaginal ultrasounds and all the techniques we use in adult population, and be very gentle with pediatric patients. So this is just a summary of what I talked about. And then if you guys are so, nice and polite and give me 1 more minute, I want to talk about transgender population as well. So in transgender population, there are treatment options available that we're happy to offer them. And this is to alleviate the distress associated with the gender dysphoria they have. And in general, what the treatment is offered to them is medical treatment that's aimed at suppression of their assigned gender sexual characteristics, gender-affirming hormone treatment, and sex reassignment surgery. So the treatment options do bring with them significant fertility risk that should be considered when somebody's counseling the trans person during the transition. The short-term effect of the gender-affirming hormone treatment is reversible, but the long-term effect on fertility preservation outcomes, and the future reproductive potential is still unclear, and there is just not enough research done yet. The surgery is irreversible, most often leads to sterility. So those decisions have to be made very carefully and potentially, hopefully, will not leave any place for regret. And options for preserving fertility prior to surgery or hormone therapy should be discussed with these patients. Now, what can we offer based on the, now graph that you already know? We can offer to transgender population the same things. And we are now talking about more trans men, people with ovaries. So it's still very uncommon, but it's possible to do that if there is a prepubertal decision making, then ovarian tissue cryopreservation can be offered. And then in postpubertal patients, embryo freezing of ovarian tissue cryopreservation can be made. So thank you very much for your attention, and I am open to questions at any time.